Welcome back, everyone. Okay, let's just dive straight into this. Today, we are taking a completely zero compromise approach. This isn't your standard surface level overview. We are doing a slow, deliberate masterclass walkthrough of the Pharmacology and Therapeutics Predicted Exam paper. We're literally leaving no stone unturned here, no pathway undefined, no trial name forgotten. If you are focused and ready to lock in a perfect score, you're in the exact right place. So let's get our foundation set. Here's our game plan. We're flipping the paper today to tackle the most demanding essay questions first, bleeding and arrhythmias, followed by diabetes therapies. Once we've built that base, we'll fire through the specific organ system short notes: cardiovascular, endocrine, neurology, NSAIDs, respiratory, and bone. Section 1. Bleeding disorders and arrhythmias. To answer these essay questions perfectly, you absolutely need a step-by-step understanding of the coagulation and cardiac pathways. Take a look at this incredibly comprehensive table. Answering this essay requires you to define exactly where we can intervene to either replace, stimulate, or inhibit the coagulation cascade. You really cannot miss a single detail here. Let's start with the antifibrinolytics, tranexamic and aminocaproic acid. Their exact mechanism? They competitively bind lysine-binding sites on plasminogen. And when you write that down, you must not forget to mention the CRUSH-2 trial, which proved that tranexamic acid significantly reduces mortality. Next up, desmopressin, or DDAVP. Now, this is a V2 receptor agonist, and it stimulates the release of stored von Willebrand factor and factor VIII from endothelial Weibel-Palade bodies. Yes, you have to name those specific bodies. But here's the catch. The consequence of repeated use is tachyphylaxis, simply because you deplete those Weibel-Palade body stores over time. Moving on to clotting factor concentrates, we have factor VIII, factor IX, and crucially, recombinant factor 7A, which goes by Novo7. We also have prothrombin complex concentrate, or PCC, and FEBA. Then, of course, there's vitamin K, an essential cofactor, and fresh frozen plasma, or FFP. Now, if you need immediate factor replacement, FFP provides it, but you must list its severe risks: TACO, which is transfusion-associated circulatory overload, and TRALI. Finally, our absolute game changer here, emicizumab. This is a bispecific antibody. It works by simultaneously binding activated factor IX and factor X, literally physically linking them together. Moving to the second row of major essays, we hit the von Williams classification for arrhythmias. Let's walk through this one deliberately. Class IA agents like quinidine and disopyramide actually increase both the QT interval and the QRS complex on an ECG. Class IB agents like lidocaine specifically target ischemic tissue. Class IC agents like flecainide are absolutely critical to master. You must state the CAST trial contraindication. The CAST trial proved these drugs actually increase mortality, so they are strictly contraindicated post-MI. Class 2 are our beta blockers. Their cellular mechanism is reducing the funny current, or AF, in the SA node. Class 3 are the potassium channel blockers. By blocking potassium, they increase the QT interval, which brings the very specific, dangerous risk of Torsades-D points. In Class 4 are the calcium channel blockers, like verapamil and diltiazem. For the exam, note their strict WPW contraindication. They must never, ever be used in Wolff-Parkinson-White syndrome. So the really crucial point here is that von Williams isn't perfect, and we have to master the exceptions to get those top marks. Let's look at amiodarone. It's actually a multi-class drug covering classes I through V, and it has a massive half-life of 25 to 110 days. Because of that, you must memorize its massive side effect profile using the PTCL-FS mnemonic: pulmonary fibrosis, thyroid dysfunction, corneal microdeposits, liver hepatotoxicity, flushing with photosensitivity, and finally S for side effects like peripheral neuropathy. Sotalol is another major exception, representing a Class 2 and Class 3 combination. Then we have adenosine, a Class V agent. Its mechanism is just beautifully specific. It binds the A1 receptor, which couples to the G protein. This triggers the IK duo or GRK channel current, causing massive cellular hyperpolarization. This sudden hyperpolarization terminates the arrhythmia, and its half-life is an incredibly short 10 seconds. And finally, you need to state the limitations of von Williams. It completely ignores drugs like digoxin, which is exactly why we need to mention the 2018 Lee et al. Revision.
Section 2. Diabetes Pharmacological Therapies. This all links straight back to cellular receptor physiology. Let's unpack the exact mechanisms used to manage both type 1 and type 2 diabetes. Step by step, we have to lay out the cause, mechanism, and consequence of exogenous insulin binding for type 1 diabetes. Keep in mind, this cannot be given orally because these peptides would just degrade in the GI tract. At the cellular level, step 1, insulin binds to the alpha subunits of a receptor tyrosine kinase, or RTK. Step 2, this binding triggers the beta subunits to undergo autophosphorylation. Step 3, that phosphorylation activates the IRS1 and IRS2 adapter proteins. Step 4, these proteins then trigger the PI3K/AKT signaling cascade. Step 5, the direct physical consequence of this whole cascade is that GLUT4 transporters translocate right to the plasma membrane. Step 6, once at the membrane, they allow facilitated glucose uptake. And simultaneously, this exact same cascade suppresses gluconeogenesis in the liver by reducing PEPCK. Now for type 2 diabetes, take a really deliberate look at this table. You must not mix up your receptor targets here. Let's go down the list. First, the biguanides like metformin. The mechanism? It activates AMP. This reduces ACC and SREBP1C, which ultimately reduces gluconeogenesis. You absolutely must reference the UKPDS trial here. Next, sulfonylureas. They bind the SIR1 subunit, which closes the KATP channels. This forces a calcium influx, stimulating insulin release. The clinical impact of that? A strict hypoglycemia risk. Then, GLP-1 agonists like exenatide and liraglutide. They are DPP-4 resistant, and you must note the LEADER trial. Related to this are the DPP-4 inhibitors themselves, known as the gliptins. Next up, SGLT2 inhibitors, like empagliflozin. They cause massive glycosuria. You must cite the EMPA-REG trial here, and specifically note the rare but very severe risk of Fournier's gangrene. Lastly, the TZDs like pioglitazone, which work via the PPR gamma mechanism. Section 3, Cardiovascular and Clotting. Now we're shifting gears from the big essays to our rapid-fire short questions, applying that deep systemic knowledge. Let's trace the full logic of warfarin. Step 1. Warfarin competitively inhibits the enzyme VKOCR1. Step 2. Because of this inhibition, vitamin K epoxide cannot be recycled back to its active form, KH2. Step 3. Without that active KH2, there is reduced gamma-glutamyl carboxylation of factors I, 7, 9, and X. Step 4. Factor 7 depletes first because it has the shortest half-life of about 6 hours. Step 5. Now here's the tricky physiological exception you must explain. Warfarin also blocks the anticoagulant proteins C and S. This actually causes a transient procoagulant state, which strictly requires a 5-day heparin overlap when you initiate therapy. Step 6. We monitor it via the INR. The exact formula you need to write down is the patient's prothrombin time divided by the geometric mean prothrombin time, all taken to the power of the ISI. The clinical target is usually 2.0 to 3.0.
Side by side, we can see exactly why NOACs are displacing warfarin. Warfarin is an indirect inhibitor affecting multiple factors with totally unpredictable pharmacokinetics, a day-long onset, and it requires vitamin K or PCC for reversal. NOACs, however, are highly targeted. We have dabigatran, which is a direct thrombin inhibitor. Then we have apixaban and rivaroxaban, which are direct factor XA inhibitors. They work right on the active serine site. Because they are direct, they offer predictable pharmacokinetics and rapid onset. Crucially, you must name their specific antidotes to secure full marks. Adarosuzumab is the antidote for dabigatran, and andexanet alpha is the antidote for the factor XA inhibitors. what's really interesting about this next slide is the paradigm shift regarding beta blockers in chronic heart failure. It seems counterintuitive, right? But normally, chronic sympathetic overstimulation leads to beta-1 receptor downregulation via the GRK and beta-arrestin internalization pathway. By giving beta blockers, the mechanism actually reduces heart rate and myocardial oxygen demand, reversing that pathological remodeling. It also reduces renin release by blocking beta-1 receptors on the JGA. You must outline the preferred agents and their trials. Bisoprolol is beta-1 selective, proven in CIBS-2. Carvedilol also includes alpha-1 blockade, proven in Copernicus. Metoprolol succinate was proven in MERIT-HF. Propranolol is non-preferred because it causes unopposed peripheral vasoconstriction. And the absolute critical clinical rule here, you start low, titrate slowly, and never initiate these in an acutely decompensated patient. Over time, they restore cardiac sensitivity, but acutely, they can be dangerous. Notice the sequence of events here with statins. It's not just the direct enzyme inhibition, it's the genetic knock-on effect. Step 1. Statins competitively inhibit HMG-CoA reductase, which is our rate-limiting enzyme. Step 2. Because of this, intrahepatic cholesterol drops. This specific drop activates SREBPs, sterol regulatory element binding proteins. Step 3. These SREBPs migrate into the nucleus and increase the transcription of the LDL receptor gene. Step 4. This increased transcription leads to increased LDL receptor expression right on the hepatocyte surface. Step 5. The ultimate consequence is enhanced receptor-mediated endocytosis of LDL, which drops plasma LDL cholesterol by a massive 25 to 60%. Section 4, Endocrine and Neurology. First class work so far, guys. Let's shift gears to neurology and endocrine short questions, starting with a classic drug interaction crisis. The cheese effect. This builds perfectly on our transporter knowledge to explain exactly why eating aged cheese on an MAOI can push blood pressure over 200/130. Step 1. MAOIs irreversibly inhibit MAOA, completely preventing the normal gut and liver breakdown of tyramine. Step 2. This undegraded tyramine enters the systemic circulation and is actively taken up by NET into your sympathetic nerve terminals. Step 3. Inside, tyramine intensely competes with VMAT, literally displacing stored noradrenaline, or NA, out of the vesicles. Step 4. This massive pool of NA builds up in the cytoplasm and violently escapes into the synapse via reverse NET. Step 5. Because it isn't being degraded, this wave of NA intensely stimulates alpha-1 receptors, causing extreme vasoconstriction and beta-1 receptors, spiking the heart rate. Step 6. The vital rescue treatment for this crisis is IV phentolamine, which is a non-selective alpha antagonist used to break that severe vasoconstriction. Acyclovir is honestly incredibly elegant. The virus essentially weaponizes its own enzymes to terminate itself. Step 1. Viral thymidine kinase, or TK, performs the initial phosphorylation from acyclovir to acyclovir monophosphate, and it does this 30 times faster than the host's own enzymes. Step 2. Then, normal host kinases come in and complete the phosphorylation to the active acyclovir triphosphate, or ACVTP. Step 3. This ACVTP competes directly with DGTP, possessing 100 times greater affinity for the viral DNA polymerase. Step 4. Once it gets incorporated into the viral DNA, it fundamentally lacks a 3-OH group. Without that 3-OH group, no further nucleotides can attach, causing obligate chain termination. Section 5, NSAIDs, respiratory, and bone. Finally, we are bringing it home with 3 crucial systems. Let's finish strong and lock in these last marks. We must completely map out these side effects because they stem directly from exactly where the inhibited prostaglandins were serving protective functions. Gastrointestinal, the loss of protective PG2, which normally stimulates mucus, bicarbonate, and EP3 acid inhibition, straight up causes ulcers. Renal, reduced PG2 and PGI2 causes afferent arteriolar constriction, leading to acute kidney injury. Cardiovascular, COX-2 selective drugs, the COXIBs, drop protective PGI2 but leave pro-aggregatory TXA2 completely untouched. This triggers a dangerous prothrombotic state, proven by the VIGOR and APPROVE trials. Respiratory. Aspirin exacerbated respiratory disease, or AERD, happens because arachidonic acid gets shunted down the 5-LOX pathway. This generates LTC4 and LTD4 leukotrienes, causing massive bronchoconstriction. And finally, do not forget to list Ray's syndrome in children, liver toxicity, and lithium toxicity due to reduced renal clearance. Now let's trace the complete intracellular cascade of salbutamol. These 4 distinct pathways show that bronchodilation isn't just one simple switch. It's a multi-pronged assault on smooth muscle. Step 1. Salbutamol binds the beta-2 adrenoceptor, activating the GS protein and adenylyl cyclase. Step 2. This increases CAMP, which activates protein kinase A, or PKA.
From here, PKA has 4 distinct actions you need to list. Step 3, PKA phosphorylates and inactivates MLCK, reducing cross-bridge formation. Step 4, PKA phosphorylates phospholambin, which disinhibits SERCA to promote calcium reuptake. Step 5, PKA opens BKC channels causing membrane hyperpolarization. Step 6, PKA activates eNOS. This increases nitric oxide, raising cGMP, which finally leads to MLCP activation. And this brilliantly illustrates our final drug class, bisphosphonates. We compare 2 categories here. The nitrogen-containing bisphosphonates, like alendronate and zoledronate, inhibit FPP synthase. This reduces prenylation, which ultimately triggers osteoclast apoptosis. This specific mechanism dictates incredibly long-term bone half-lives of over 10 years. Conversely, the non-nitrogen-containing agents, like atadronate, just create toxic ATP metabolites that destroy the cell. Because of severe local GI toxicity, you must state the strict pharmacokinetic rules. They must be taken fasting, and the patient has to remain upright for 30 to 60 minutes. Lastly, the defining adverse effects. You must explicitly write down atypical femoral fractures and osteonecrosis of the jaw. Look at the depth of what we've covered today. From the exact binding site of a bisphosphonate to the molecular reason an MAOI causes a hypertensive crisis, you now have the complete, unbroken chain of logic. So ask yourself, if you can trace the mechanism from a specific receptor binding directly to its clinical outcome, and then back it all up with a critical trial data like Vigor, Approve, or CAST, can you ever really lose a mark in pharmacology? Keep reviewing these structural pathways until the cause, the mechanism, and the clinical consequence are completely second nature. Best of luck on the exam, focus learners. You are going to absolutely crush this paper.